This afternoon, we'll be looking at antimicrobial agents. The reason for this echo is that we are trying to address the problem of antimicrobial resistance. And this problem occurs when microorganisms stop responding to antimicrobials. And that is why we've come up with this initiative to try and disseminate information regarding antimicrobial agents, their use, and also factors that contribute to antimicrobial resistance. So this afternoon, we have a great presentation from our chief pharmacist, Mr. Kandandu, Minister of Health. So he will give us an introduction to antimicrobial agents, the types, and also their rational use. And also on the panel, we have got a group of experts. Among them, we have Mr. Andrew Bambala, pharmacist. We also have Mr. Simunyola, the pharmacist as well, and Mr. Roosevelt, Kyanimina, Ms. Uchizi, our own Dr. Kapolowe, and Dr. Matele, as well as pharmacist Mr. Chikatula. So this is a very, very good team, various expertise. So we urge everyone to stay around, listen, and also ask questions and make contributions at the end of the presentation. I'll be your facilitator, Dr. Stewart Mdenda. Mr. Chibosha, are we here?
We can't hear you, facilitator. We can't hear you.
Yes, I am. Yes, I am.
Yeah, Mr. Chibosha is able to hear me.
Yes, we are able to hear you.
How are you?
I'm exceptionally well.
I'm awesome. So, the presenter is able to hear me.
We are getting you.
Awesome. Thank you so much. So we'll have a presentation from our chief pharmacist, Mr. Chibosha, and also our team of experts will be able to respond to the questions and also add some contributions. So, Mr. Chibosha, it's your time to present. Feel free and feel at home.
Thank you so much, colleagues, and good morning. As Mr. Mdenda said, I'm Kandandu Chibosha, Chief Pharmacist, based at Ministry of Health for Rational Medicine Use. And I'll take you through this presentation to talk about the antimicrobial agents. Our objective by the end of the session is that all our participants will be able to describe the different types of antimicrobial agents and also to define the rational use of antimicrobials. Very, very critical objectives for us as Ministry of Health. Yeah. So before maybe we dwell much into the presentation, we have a number of questions that maybe the participants can respond to. The first one is, number one, we have three questions. A bactericidal antibiotic kills bacteria without relying on the patient's immune system. Sorry, colleagues, for that. And please monitor your gadgets and make sure that you are mute so that you don't disturb everybody. Yeah, so the first question, you can respond to the first question. to respond. So give you 1 minute to respond to the first question.
Dear participants, let's respond to the question. It's just either a true or false. So we have only 25 that have responded out of the 42 participants. Let's respond so that we win at the end of the session.
I'll go to the next question. Okay. So we are going to go into the presentation now. The first question, we have ended the post. And then with the first slide, we are going to look at the definitions of what antibiotics are. And in our presentation, we have said a natural substance produced by one type of microorganism which inhibits or kills other organisms. And these agents selectively kill or inhibits the growth of microorganisms while having little or none effect to the mammalian host. So they are specific to the microorganisms, but not to the person or the host. And the antimicrobial agents, in terms of rational use, this is when patients receive antimicrobials appropriate to their clinical needs in doses that meet their requirements for an adequate period of time and at the lowest cost to them and their community. So key issues here are issues to do with appropriate use and also tailored to the clinical needs. But also we need to be mindful of the doses that meet their requirements, because without providing adequate doses, we're just promoting resistance. And it must be for the specified period. And also we need to bear in mind the issue of the cost. It should be at the lowest cost, but also beneficial to the client. In terms of classification of antimicrobial agents, we have 5 specific areas in which we can classify our antimicrobial agents. The first one is the therapeutics use, or the organisms that are affected. Then we can describe them according to spectrum of activity. The other option is the type of action that they exert, and also the structure and mechanism of action. The list is the WHO aware classification. We'll look now into each one of them. So when we say classifying antimicrobial agents based on their therapeutic use or organisms affected, here what we are talking about is we have the antibacterial drugs. That is a drug that inhibits or kills bacteria. An example is amoxicillin. These will specifically act or deal with the bacterials. Then the other classification under the therapeutic use is the antifungals. That is the drug that inhibits or kills fungi. And an example of this is fluconazole. Antiviral agents, a drug used to inhibit viral activity, acyclovir, or the and viral agents, or the ARVs in large. The antiparasitic drugs, that is a drug used to inhibit or kill parasites. An example is the bendazole. So this is the first classification of antimicrobial agents based on the organisms that they affect. The other classification is the spectrum of activity. We have the narrow spectrum antimicrobials that targets only the specific subsets of the pathogens. An example of such is the vancomycin and penicillin G, targeting the gram-positive, also azithromycin, colistin, and gentamicin targeting the gram-positive. So here we have the gram-negative and the gram-positive. So the narrow therapeutics, the narrow spectrum antimicrobials, they will be specific in what they target. Either they will target the gram-negative or they will target the gram-positive. However, the broad spectrum antimicrobials will target a wide variety of pathogens, including both gram-negative and gram-positive pathogens. And some of the examples are the ciprofloxacin, the chloraphenco, the cefotaxime. The other classification is by the type in terms of the effect, how effective they are and how they exert their effects. The bacteriostatic, which we can call static antimicrobials, they prevent the organisms from multiplying, but it is the patient's own immune system which kills off the bacteria and leads to recovery from the infection. So they will exert some effect to inhibit the multiplication of the microorganisms. That is to facilitate the body's immunity to kill or to eliminate the bacteria. Then the bacteriostatic drugs cause reversible inhibition of growth, with bacterial growth restarting after the elimination of the drug in the blood system. That's why when we talk of adequate duration of treatment, it is very, very critical, because once the drug is eliminated from the system, it means the bacteria can still restart growing again. An example for a bacteriostatic drug or antimicrobial agent is the tetracycline. Then we have the bactericidal. These, they kill the bacteria without relying on the patient's immune system to help. And an example are the penicillins that we have. The other way to describe our antimicrobial agents is by chemical structure or mechanism of action. When you look at this slide, it gives us a lot of areas where the antimicrobials can act. We'll start with the first on top, which is the cell membrane synthesis, disruption of disruptors, those which can stop the synthesis of the cell membrane. And the examples are the lipopeptides. Then we have the folate synthesis inhibitors, the sulfonamides. Then we have the protein synthesis inhibitors, the tetracyclines. The arrows are indicating where they act in terms of in the cell. We have also the RNA synthesis inhibitors, and we have the DNA gyrase inhibitors, the quinolones, also the inhibition of the DNA-dependent RNA polymerase, the rifampicin. We also have the cell wall synthesis inhibitors, the beta-lactams, and this description just shows you at which site of the cell do the antimicrobials act. So you can use this mode to describe our antimicrobials, because different antimicrobials act at different sites of the cell to exert their effects. The fifth way you can classify the antimicrobials is to follow the WHO classification. Under the WHO, we have the access, the watch, and the reserve, which is commonly known as the aware classification. In terms of the access, which access includes or indicates the antibiotics of choice for each of the 25 most common infections. So WHO looks at the most common infections, and then the 25 of them are prominent, and they look at which antimicrobials can be used to treat these microorganisms. So these antibiotics should be available at all times, affordable, and quality assured in terms of potency. The watch. These watch includes most of the highest priority critical important antimicrobials for human medicine and for veterinary use. These antibiotics are recommended only for specific limited indications. And then the reserve antibiotics that should be only used as a last resort when all other antibiotics have failed. In our scenario, as a country, when we want to apply this classification, you'll find that most of our access drugs are those which should be readily available in our facilities, used in OPD. Some of the watch drugs are those which needs to be on the watch list, and then we should have the reserves. And we are trying as a ministry to see how we can harmonize our documents so that we can be able to guard the reserve and the watch and provide more of the access for us to provide quality health services to our communities. We'll pause for the second question, which reads, vancomycin is an example of a broad spectrum antibiotic agent. True or false? Again, you can score. We'll give you 1 minute to score. Let's continue scoring. We're remaining with 10 seconds. Okay, we will proceed. We have 40% true and 60% false. Okay. So when we talk of rational use of antimicrobials, when we talk of rational use of antimicrobials, we are specifically interested in the appropriate use of antimicrobials based on the clinical needs in the doses that meet the requirements for the client, which must be adequate for and also in a good period of time to meet the client's desires, but also at the lowest cost. So, truly speaking, when you reflect in our scenario, we can say 50% of our drugs are used irrationally, and the irrational use occurs when one or more of these conditions above is not met. If the drug is given to a client who did not maybe meet the criteria, then that is irrational. If the drug is given to a client whose condition is not does not appear in the guidelines as a clinical indication for that drug, again, it is irrational. Issues to do with doses borders on irrational medicine use. So we will look at some of the examples of irrational use of medicines. We have the use of too many antimicrobial medicines per patient, also known as polypharmacy. This is a critical issue for us. Some surveys we have done or some facilities we have visited, we have found that clients are going with 2 or 3 antimicrobials right from outpatient department. Whether that is rational or irrational, it requires more investigations from us to establish the truth. Also, inappropriate use of antimicrobials, often in inadequate dosages, and for non-bacterial infections. In the current scenario that we are coming from, where the flu was so much and it had attacked almost everyone, and there was a lot of self-prescription. I think a lot of people, even you colleagues attending here, you have prescribed some antimicrobials for yourselves, even when you truly know to say the flu was caused by a virus, and the antimicrobial, maybe the antibiotic did not had any role to play. The other one is the non-adherence to clinical guidelines. We know that most of our staff are trained from different organizations, and when they join these institutions, they find a variety of antimicrobials being stocked at the facility, and they want to showcase the best practices that they have. So if there are no orientations provided to these colleagues of ours, you'll find that they will not adhere to the clinical guidelines that are provided for, and that will cause irrational use of medicines. The other example is inappropriate self-medication, often with prescription-only medicines. I referred to the flu that we had, where a lot of people have been prescribing medicines for themselves, even getting maybe to the retail to buy for themselves, and also non-adherence to dosing regimens, where you are prescribed maybe antimicrobials for 5 days, you take for 3 days, you feel better, you stop. That is also bordering on irrational use. In terms of the cycle of antimicrobial use, really antimicrobial use or inappropriate use of antimicrobials drugs may happen at any of the 4 main stages of the antimicrobial cycle. The diagnosis is very critical, it's a critical cycle for us to rely on the evidence-based prescribing habits, where we send to the lab gives us the organism that we want to target, and then we will prescribe according to what the treatment guidelines are providing for. But you'll find really at diagnosis level, if we are not very careful, a lot of inappropriate use happens at this level. The prescribing level equally, because it's a critical point to make decisions based on what we have heard from the client, is another critical point where inappropriate use of antimicrobials can happen. The dispensing point is another critical one. And the patient adhering to the instructions given is another critical one. So when we are looking at resistance, antimicrobial, inappropriate use of antimicrobial, we need to bear in mind the 4 cycle or the 4 stages in this cycle that are very critical, so that if we are to put up interventions to promote rational utilization of antimicrobials, we need to pay attention at every point of the cycle. That will give us a holistic approach to address irrational medicine use. What are some of the strategies that the ministry provides for in terms of improving antimicrobial use? Number 1 is we have the educational strategy, where we hope to train health workers, induct health workers, the newly employed health workers on how institutions are performing or how they work within their institution. So it's very, very critical to train health workers, and that's why we're providing this platform. And also we need to induct new members of staff in our institutions so that we guide them how our institutions are running these programs, so that there's adherence and there's a standard way of practice that we introduce in our systems. Also printed materials. As a ministry, we are in the process of revising our reference documents. We're almost concluding, so that we update them to the latest provisions of practice. The Zambia National Formulary, the Standard Treatment Guidelines, the Essential Medicines List, we are working on those so that we provide the printed materials to the lowest level of facilities up to the highest. Approaches based on face-to-face contact. We need to educate our community, educate ourselves on the best ways to improve antimicrobial use. The other one is the managerial strategies, where we conduct some monitoring, supervision, and feedback. Here we critically look at the selection of the drugs that we have based on the institutional formulary. Who should prescribe what, and which drugs should be in the reserve, in the watch. Within the institution, we need to come up with mechanisms that can help us to adhere to this. And that will help us to select, procure, and distribute, prescribe, and dispense correctly in order to uphold antimicrobial use. The other strategies, the economic strategies, where we look at the price setting and also capitation-based budgeting, where we are thinking of maybe allocating budgets to the districts. You draw your commodities, you finish your allocation, we tell you you are done with your quantities. Because you can't keep on drawing quantities for other facilities which are adhering to rational medicine use, and also reimbursement and user fees. These are like linkages with the NEMA accredited facilities. These can help us also in terms of promoting antimicrobial use. Health insurance schemes is one of the economic strategies that we can use within the institution. The regulatory strategies, here we are looking at, are we dealing with the registered medicines? Our belief and understanding is all the antimicrobials must be registered by ZAMRA, so that we are able to quantify how much came into the country. Since we do not manufacture any antimicrobials, we can go to ZAMRA, pull all the data to see how much amoxicillin came into the country. And that can help us to quantify and put up mechanisms as to which drug is mostly prescribed. And then we relate it to the AWARE list, the WHO AWARE list. Also limited medicine lists. This can be at facility level, where you develop your essential medicines list, adapting it from the Zambia National Formulary or from the British National Formulary. The prescribing restrictions, these are also regulatory issues. Remember, they are over-the-counter drugs, prescription-only medicines, and pharmacy-only medicines. These are put to help improve antimicrobial use. Dispensing restrictions, there are those who can dispense over the counter. There are those where you need a prescription. Are we adhering to this as we try to promote antimicrobial use? And vigilance and the post-marketing surveillance, very, very key. We need to get feedback from the ground in terms of the potence of our medicines, vis-a-vis the storage conditions under which they are kept at lower levels. So we need also to enhance issues to do with vigilance, which falls under ZAMRA as our regulatory authority. We'll look at the poll question number 3. According to WHO AWARE classification, access antibiotics include all beta-lactam antibiotics. True or false? You can score. We'll give you 1 minute to score. 10 seconds more to go. We have 68 people participating. So far, only 34 have responded. Others are still debating. Please continue scoring. We are done. Okay. So what are the benefits of rational use of antimicrobials? One of the benefits is that it will improve patient outcome because we'll be very specific in terms of how we are treating our clients. We'll know the cause, we'll know which antimicrobial is recommended, and therefore we use the correct antimicrobial, and that will result into improving infection cure rates. So if we are to adhere and promote rational medicine use, we will be very specific and we are going to improve infection cure rate. Number two is the benefit of rational medicine use is improving patient safety as it minimizes bacterial toxicity because we will be very specific. The other benefit is that it will reduce antimicrobial resistance because we'll be restricting the use of broad spectrum antimicrobials agents. Where we need narrow spectrum antibiotics, we'll be very specific to treat that and reserve the broad spectrum. The other benefit is it will reduce healthcare costs, age-strengthened antimicrobial stewardship programs, which can reduce healthcare costs through the prudent use of antimicrobials. The fourth one is very, very key because it puts pressure on the demand and then resource mobilization. You bear me witness to say our budgets for medicines are not adequate. Therefore, if we do not adhere to rational medicine use, we will increase the cost for medicines unnecessarily, and that puts pressure on the leadership, facility leadership, and maybe Minister of Health leadership to look for more money to buy the commodities. So if we were to adhere to promote antimicrobial usage, all these four benefits put together, they will go a long way and our services will still remain quality. What are the summary key points for today's presentation? What we are encouraging the facilities are that antimicrobials can be classified in terms of the classification, 5 key classifications. We urge you to understand them. That is therapeutic use by organism involved. Either you classify them by spectrum of activity, the broad, narrow, the type of action and structure where they act in terms of mechanism of action, and the WHO aware classification, the access, the watch, and the reserve. And all healthcare workers have a role in promoting rational antimicrobial use. It should be a multi-sectoral approach. It's not one unit. The prescribers needs to play their role. The pharmacy team needs to play their role. The nurses, the lab team. So everybody, including the administration, they need to play their role in terms of ensuring that all our practitioners are adhering to the treatment guidelines. The other key point is that MOH is revising the STG, the Zambia National Formula, the Zambian Essential Medicines List, and the Antimicrobial Stewardship Guidelines to promote rational medicine use. These are very, very key points for us, and we want by September, we may have our last meeting to validate the review of these documents so that we can launch them maybe before the end of the year, and then we'll start using them 2025. In addition to these documents, we are linking our Zambian Essential Medicines List to ZAMMSA so that we tie the issuing of commodities to the level of care provided for in the essential medicines list. We want to avoid a situation where commodities can go up to the health post, and meanwhile, those commodities are not supposed to be used at health post. And as we try to stabilize the supply chain in terms of ensuring that medicines are available, which I think from health post to health center, we are above 80%, then hospital level, from first level maybe to tertiary, we are around 70%. As we guide ZAMMSA where commodities should go, I think they will provide guidance in terms of promoting adherence to rational medicine use. Those are some of the references that were used in this presentation, and we will share the presentations for you to be able to track some of the references that we have used. In terms of the question that we had, you can gauge yourself in terms of where the correct answers. And the first question is, a antibiotic kills bacteria without relying on the patient's immune system. That is true. Vancomycin is an example of a broad spectrum antibiotic. It's false because it is a narrow therapeutic product. According to WHO aware list classification, access antibiotics include all beta-lactam antibiotics. Again, is false. In terms of any questions, you can contact me on that number, and this number is the only number on WhatsApp, but also I have the email address indicated there for you to be able to get to us and maybe get more clarification. Moderator, the presentation has come to an end. I hand over to you, Dr. Mdele.
Thank you so much, Mr. Chibosha. That was a great presentation. Dear members, you have heard. We have classified antimicrobial agents, and we've given examples. We've also labored much to talk about the WHO aware classification of antibiotics. And then we have also discussed the rational use of antimicrobials. This is very, very critical to avoid or reduce emergence of antimicrobial resistance. At this point, I'll open the floor for questions. Feel free to participate. Mr. Chibosha is here, and there is also a panel of experts. Those with questions or contributions. Any questions or contributions to the listeners? Okay, to our experts on the panel, Dr. Kapolowe, how can we promote a rational use of antimicrobials so that we minimize or reduce the negative impacts of antimicrobial resistance on our nation?
Chair, I don't think Dr. Kapolowe is on the call.
Oh, sorry. He was around. Okay, anyone on the expert panel? Expert panel, how can we promote rational use of antimicrobials to avoid or reduce the impacts of antimicrobial resistance on our communities in Zambia? Seems our experts are not here. All right, there's a question for you, Mr. Chibosha, in the inbox. What has the government done to reduce
antimicrobial resistance, more especially with veterinary medications?
Brenda, and thank you so much, Mr. Kalisa, for this question. Truly speaking, your concern is our concern. As you know, to say, and microbial agents are utilized, or they are used also in the animal health. So at national level, we are working with one slogan that talks about One Health. One Health in the sense that we have the human health, which uses antimicrobials. We have the animal health that uses antimicrobials. And we have the environment, which also maybe some of the expired commodities are thrown in the environment. So we have a steering committee at national level where we all meet to discuss the antimicrobial usage or resistance in terms of a holistic approach. And our committee is gaining a lot of momentum, and at national level, we seem to be stable in terms of working together, the vet, the environment, and the animal health. And recently, we had some trainings in Kabwe where we are looking at issues to do with the rolling out to the sub-region. Sub-region in terms of the provinces, we need to create leadership at provincial level so that equally they can work together as a team from the three corners of One Health. That is the Ministry of Health, Environment, and also the veterinary. So those are some of the efforts we are doing, but also we are training a lot of health workers in terms of forming up the antimicrobial stewardship committees within the facilities through the scope or the umbrella of the Medicines and Therapeutics Committee. It's our wish that all our high volume facilities have these committees in place, and these committees are functional, especially when we look at human health, so that they are able to look at issues to do with supply chain issues in terms of the commodities they need within the facility. Also look at the utilization of what they have received. How are they using the commodities that they have received? But also we are also encouraging these committees to look at issues of infection prevention so that they address issues of how clean is our environment to avoid maybe clients coming without infection and only to get infection from our institutions. The other critical area we are encouraging the Medicine and Therapeutics Committee to look at is the data that they push into the AMS. Are we able to compare the consumption of our antimicrobials within human health or within our facilities with the statistics, same statistics, the numbers of plants that the facilities are seeing? Or we have disparities where there is so much consumption, and then when you look at the numbers of clients that would have been purported to receive those commodities, they are very less. But also to look at if they were prescribed antibiotics, were they rational? Was the prescriptions genuine to guarantee the issuing of those commodities? So really there's a lot that is happening, Chair. And we have already trained the provincial clinical care specialists, the biomedical scientists, the chief pharmacists from provincial level in all the 11 provinces, the 10 provinces of the country, and we have capacity built them. Our expectation is they will roll out to the district level so that district pharmacists, hospital pharmacists equally work hard to improve antimicrobial resistance. So I think those are some of the efforts that the ministry is doing. In addition to that, budget increase has made it possible to have a variety of antimicrobials where our staff can choose from in terms of promoting rational. In the past, where we had only maybe one antibiotic available at facility, it was difficult to encourage facilities to uphold the issues of adhering to treatment protocols. But now, several antibiotics are available at a facility. Our expectation is, as much as we are doing at national level, what are you doing also at facility level to ensure that we rationalize our commodities and promote rational medicine use and guard against resistance? Chair, I submit. Thank you.
Thank you so much, Mr. Chibosha. So there's also some 3 concerns in the inbox. I think one I can summarize is, are we implementing any antimicrobial stewardship programs in retail pharmacies? And the other one is there a policy, or is there a way that we can discourage community members from buying antibiotics without a prescription from drugstores? And also the last one is that the community out there do not know about antimicrobial resistance. So is there a way, are there methods we're using or mechanisms to sensitize the communities about antimicrobial resistance? If we have those mechanisms, in which ways can we reach out to the community so that they understand antimicrobial resistance and its implications? Mr. Chibosha, or if we have any experts on the call. If not, Mr. Chibosha can go ahead.
Thank you so much, colleagues. Your concerns again are very critical. In terms of regulating the farmers, this area is being managed by ZAMRA, and I think ZAMRA is also enhancing their monitoring mechanisms to address adherence by the retail chemists to the protocols that are designed by ZAMRA to manage a farmers. But colleagues, the responsibility lies on all of us. It's not an issue of maybe just the Minister of Health at national level to address this issue. It cuts across right from national level up to the service delivery point and up to the community who are the end users. So issues to do with the control of access to antimicrobials in the retail farmers, ZAMRA has guidelines to that. But as much as ZAMRA has guidelines, ZAMRA is not everywhere. So it takes the responsible officer in that chemist to uphold the dignity that ZAMRA has put across in order to operate that retail chemist. We should be able to self-retrospect or to reflect at an individual level so that you are happy with the way you are operating. But we are very much aware to say, I think for now, there are issues of sort of what I may call free access to medicines, because as the managers, we are not upholding our guidelines to the level that we are expected to uphold. Our request with ZAMRA to work closely with ZAMRA is to enhance the control measures and the adherence to access to medicines. So we are very much aware. But also we need to educate our community. We need to sensitize our community to say access to medicines must be done in the provided maybe guidelines that are there. And as much as we educate our community, we also need to educate our facility staff and our health workers on how they should provide these commodities. In our environment, I was telling somebody last week to say, if I was to go to the farm, I can walk to any chemist and say, pack for me this, and they'll pack. And I'll deliver that to people who are not sick. That's irrational. And we are creating a huge cost on the government because those clients who we give those drugs, they were not budgeted for. The drugs that were budgeted for were for those who are sick, not for the people who are fit in their farms. But those are the areas, even at an individual level, I need to reflect, is what I'm doing legal or illegal? So sensitization is key. And sensitization can take place from national level up to the lower levels. I pick an example for Uchizi. They have a community radio station where the district team, district health team with the vet team and with the environmental team, they can go to that radio station and speak to the community within Uchizi district. And most of our districts have community radio stations. They have gatherings where they meet. They have churches where they can go to sensitize communities against, they can go and sensitize communities on rational medicine use. So really, it involves all of us at all levels. It's not just the ministry. As a ministry, yes, we are trying, but you need to support us from the grassroots so that you tailor your messages to the local community and encourage them to stay away from maybe accessing medicines in a way that is not prescribed. Chair, I think that's what I can comment. You may wish to add in case there are some people on the panel who are also able to add to this. I submit.
Thank you so much, Mr. Chibosha, for those good responses. So do you have anyone on the expert team on the call? Our experts were informed of the meeting, so they should have been here.
Hello.
Hello.
Yes, good afternoon. Thank you. This is Davis Musango from Chimwemwe Level 1 Hospital, Kitwe District. Thank you so much on the knowledge that has been shared, and we have learned that one of the ways that we can improve the use of antimicrobial is by using the WHO standard classification. And also, we would love ZAMRA to ensure that all antimicrobials are registered under their regulatory board. And also on the education strategy, by providing us with all necessary materials, and also the standard guideline books, so that we can sensitize even other clinicians and other health workers. Thank you.
Thank you so much. Thank you so much for that contribution. The Minister of Health is here, Mr. Chibosha, about the guidelines. There's a cry for guidelines in the facilities, and I think I visited a facility today and yesterday, and it's the same issue. I found that the facilities that they do not have guidelines, so they're also asking for the guidelines. Our national focal point, Dr. Chizimu, good afternoon.
Good afternoon. Thank you.
Doc, any word on the rational use of antibiotics or antimicrobials?
This is a very big challenge which we have as a country. And as I think the presenters have mentioned, the other experts have mentioned, and this is because we're able to get these drugs over the counter without any prescription. So the key is to ensure that we sensitize the Zambian community. They should know the negative impacts which are attributed to accessing these antibiotics or antimicrobials without the guidance from the clinicians. So if we build more sensitization, people will get to know and they will refrain from doing such acts. But for us who have this information, I urge everyone to advise and at least share this information with other community members so that they also promote the good use of antibiotics by only accessing these antibiotics through the use of the prescriptions. This will mean these patients or people will be seen by the doctors and be advised that
All right, seems we have lost our national focal point, Dr. Joseph Zim. All right, okay. Thank you so much. I think we've heard, in short, is trying to talk about the inappropriate use of antimicrobials. So is urging everyone to come together. Let's inform our communities. Let's inform other healthcare workers about practices that contribute to inappropriate use of antimicrobials and hence the emergence and spread of antimicrobial resistance. So as I close the meeting, I'll call upon Mr. Chibosha to give us closing remarks.
Thank you so much, Chair. Again, on behalf of the ministry, coming from the ministry point of view, for our health facilities, our request and our guidance is that stabilization in terms of supply chain, that one counted to say is done, because we are increasing even the number of health center kits from 42,000 for 2020 from 2023 to 57,000 in 2024. Our worry now is the issue of storage capacity at facility level. We are aware of your challenges, but we encourage you to double your efforts in terms of looking for extra stock, because, space, because stock will be coming. As much as stock is coming, we need to be very cautious that that stock, the government has spent a lot of money to ensure that medicines are procured. In the past, the problem was availability of essential medicines. But currently, the problem will be inadequate storage space and the irrational use of these medicines. So let us be all patriotic in the way we provide service, so that we really support government for the efforts that they have done at our level, at institutional level, to make sure that these commodities are used rationally, and utilization is reflected on to compare your consumption data with your sales data, but also we need to secure them so that they are used for the intended purpose. Equally, we need facilities to be able to give us quality data that can help us to quantify, to forecast and quantify for the following year, utilizing the AMS. So our expectation is when we visit our facilities, we need to find that the AMS stock control card, the electronic stock control card, and the paper-based, they are matching. Because for us, when we are quantifying, we pull the data from the electronic stock control cards. So please, let's do that which we are requested to do, so that holistically from national level, the efforts that the national level is putting and the efforts that the service delivery points will be put in, that will give us guarantee and stabilize the supply chain to the latter. Otherwise, moderator, I'm very, very delighted to be a presenter today and to talk to our colleagues in the regions, in the facilities. This is the way it should go. And let us guard against antimicrobial resistance. It is a global issue, a regional issue, a country issue, but also a facility issue, and it goes down up to the individual issue. So we should really look at it to say, if we delay to address these issues and adhere to what we are providing in terms of guidance, we'll lose the battle, and it will be all of us to blame. Some of us, when we started work, it was difficult to access an antibiotic because the system was so stringent that you only need a prescription from the qualified personnel after they have examined you to access these commodities. But at the moment, we seem to have lost all that. So what is it that we can do at individual level which can add value to the community that we serve? I think, Chair, the call is for everybody. I submit and say thank you so much.
Thank you so much, Mr. Chibosha. So, ladies and gentlemen, that was our presenter for today, Mr. Chibosha Kandandu. He is a pharmacist, a chief pharmacist, and an expert in rational use of medicines. I will not say antibiotics because it's all the medicines. He's an expert in rational use of medicines at our national level. So that is why we had him on this presentation today. So thank you, Mr. Chibosha, and thank you, colleagues, listeners. We are also grateful to our ECHO managers, Mr. Chatonda there. Thank you so much for making this possible. And our moderator and organizer, Ms. Loveness, we are so grateful. All our partners, we thank you so much. Let us work together. Let us unite to promote the rational use of antimicrobials and also address antimicrobial resistance. Until we meet again, I am your host, Dr. Stewart Mdenda. Bye-bye.
Thank you. Bye-bye.